Thank you very much, and thank you to the Ted Rogers Center for Heart Research and the committee for the opportunity to speak to you today. So we'll discuss today treating coronary disease and heart failure. What did we learn from Revived? I have no relevant disclosures. And over the course of today's talk, we'll illustrate the relationship between ischemic heart disease and heart failure, and then go on to explain the Revived BCIS-2 trial that was recently published in the New England Journal of Medicine and its outcomes and implications for heart failure. So what do we know about coronary artery disease and revascularization in patients with heart failure and left ventricular dysfunction? So over the course of this talk, we'll review the current literature and guidelines, discuss the Revived BCIS-2 trial, and applications to the current heart failure care. So when we think about left ventricular dysfunction in coronary disease, there are three main types of complications. So we have infarct or scar, which causes necrosis of the myocardium that's essentially irreversible. We have stunned myocardium that despite blood flow restoration, the left ventricular dysfunction persists and then eventually recovers. And we have hibernating myocardium, which despite low blood flow causes left ventricular myocardial dysfunction. And so that's what we're really going to be focusing on today, this hibernating myocardium that's still viable. And if we can restore the blood flow to this tissue, can we improve the overall function of the heart? So we know from the STITCH trial, a randomized controlled trial of over 1,200 patients that compared revascularization with coronary artery bypass grafting with surgery to medical therapy, that initially there was no difference between these groups. But when we look at the 10-year outcomes for the STITCH extension study, there was a significant survival benefit with revascularization for those patients that had left ventricular dysfunction with an ejection fraction of less than or equal to 35% and significant coronary artery disease. And they found in the STITCHES trial that the death from any cause had a hazard ratio of 0.84%. So at that 10-year outcomes evaluation, there was a significant difference. But what about the patients that receive percutaneous coronary interventions, or PCI? We've been trying to translate this information that we know from the surgical groups to those patients that are getting revascularized by PCI, but this doesn't always hold true. And when you do a review of the literature, it's kind of a plethora of mixed results, some positive trials, but they're mostly observational studies. And even in systematic review and analysis, some of the older studies were initially positive, but more recent systematic reviews have been kind of neutral on this topic. Even more recently in 2020, we have the ischemia trial by Marin and colleagues, which looked at patients that had stable coronary disease with moderate to severe ischemia. And they randomized these patients to either receive initial invasive strategy or a conservative approach. And they did not find that this did not reduce the risk of ischemic cardiovascular events or death from any cause. However, these patients that were included did not have left ventricular dysfunction less than 35%. So we're still kind of in this gray zone about what should we do with our sickest patients, perhaps, that have the most severe left ventricular dysfunction. Should we revascularize them or not? In our current guidelines for these patients with LV dysfunction and coronary disease, the Canadian Cardiovascular Society says that we can consider revascularization irrespective of angina or symptoms if they're a good candidate. Similar recommendations from the European Cardiovascular Society, with CABG getting a Class 1 recommendation and PCI 2A. And the more recent American College of Cardiology guidelines from 2021, they are more neutral and didn't actually give a specific recommendation saying that there's insufficient data for the role of PCI in left ventricular dysfunction to improve their survival or cardiovascular outcomes, which is similar to other stable coronary disease trials that we've had. So are there any randomized control trials in these heart failure patients that can help us? And up until this point, there's been a paucity of data, and we were really missing the randomized control trial that could help to guide us in this patient population until this October, where the revived BCIS-2 trial was published in the New England Journal of Medicine by Pereira and colleagues. So I'll just refer to this as the revived trial going forward. So REVIVE stands for revascularization for ischemic ventricular dysfunction. And the clinical question for this trial was, in patients that have significant left ventricular dysfunction, does revascularization by percutaneous coronary intervention, or PCI, improve event-free survival compared to optimal medical therapy alone? So the benefit of this was that it was an open-label, multi-center, prospective, randomized controlled trial that involved over 40 centers throughout the UK. And they included patients that had left ventricular systolic dysfunction of less than or equal to 35%, extensive coronary artery disease, which they classified as having a positive BCIS score, or Jeopardy score, so the amount of myocardium at risk based on the coronary anatomy of 6 or above out of 12, and then viability in at least 4 dysfunctional segments amenable to revascularization with PCI. And they excluded any patients that had had a recent acute myocardial infarction, were in acute decompensated heart failure, or had had a recent ventricular arrhythmia. And so they looked at the primary outcome of death from any cause or hospitalization for heart failure, this composite endpoint. And their secondary endpoints for the trial were improvement in left ventricular ejection fraction, improvement in NYHA functional class, and then quality of life metrics as measured by the Kansas City Cardiomyopathy Questionnaire or the EuroQol 5-dimension 5-level scores. So they randomized over 700 patients with this criteria of severe left ventricular dysfunction, extensive coronary artery disease based on Jeopardy score, and myocardial viability. And they randomized them to either receive optimal medical therapy or medical therapy plus revascularization with percutaneous coronary intervention. And I think this is traditionally what we would usually do in our standard heart failure patient care. The optimal medical therapy group was on quite good medical therapy. I think over 90% of them had been on beta blockers, ACE inhibitor or ARB, and 50% on MRA. So this was the primary outcome from the revived trial. Death from any cause or hospitalization for heart failure, as you can see in the two groups based on their plot, that there was really no significant difference. And in terms of events between the groups, if you're a more visual person for bar charts, you can see that the percentage of patients that had the primary outcome was 37% in the PCI group and 38% in optimal medical therapy. So really no difference between the two groups, with a hazard ratio of 0.99, which is insignificant. When we go on to look at the secondary outcomes, when we look at patients' improvement in left ventricular ejection fraction, there was no statistically significant difference between the two groups. This is similar to the STITCH trial, where after cabbage revascularization, there was also really no improvement in the ejection fraction. And in their KCCQ quality of life score, there was initially an improvement at 6 and 12 months for quality of life in the PCI group, but this was not sustained and not seen at the 24-month mark. So the strengths of this trial is that there was almost no loss to follow-up in those 700 patients. Data was analyzed for over 99% of the patients, and they enrolled high-risk patients with significant left ventricular dysfunction, high risk of myocardial ischemia, and they also included left main patients. So left main disease was almost 10% of the patients enrolled. The groups were quite fairly balanced, and they had blind evaluation for both heart failure hospitalizations and left ventricular ejection fraction through an echo core lab. So ultimately, in this trial, there was no statistically significant difference for these patients with severe left ventricular dysfunction and significant coronary disease in improving heart failure hospitalizations or death from any cause, and no improvement in their left ventricular ejection fraction or in their quality of life. So what does this mean for our patients with heart failure and significant coronary disease? Where does this leave us? If they're not a good candidate for revascularization through surgery, I think the best option for us is what we've been doing all along, is treating patients with optimal medical therapy, implementing the 4 pillars, really trying to get them optimized, and also implementing device therapy with implantable cardioverter defibrillator or continuous resynchronization therapy. The patients, many of them, I think over 250 patients in this study, did have a device, and it helped to prevent their mortality over time, which we know. We also, in this trial, enrolled patients with absent or limited angina, and just like the COURAGE trial, patients with stable coronary disease didn't really show any benefit in the revascularization in terms of their mortality, but we should maybe consider this for the patient that's symptomatic. Again, in terms of generalizability, which we've been discussing quite a bit today, this patient population was over 90% Caucasian, 88% of them were male, and most of them were older, above 70 years old. As I mentioned, similar to Stitch, the revascularization didn't really affect left ventricular function, which was also reflected in the REVIVE trial. And they haven't yet analyzed concordance between the arteries that were revascularized and the viable myocardial segments. So we'll have to see if actually doing this extensive PCI therapy did make any difference to the original viable myocardium or not. And then in our clinical practice, sometimes it's difficult to know, is this all ischemic cardiomyopathy? Often in our practice, sometimes it can be very mixed. Perhaps the patients have non-ischemic cardiomyopathy with bystander coronary disease, and sorting this out can be really challenging. And although the patients were evaluated for this specifically for enrollment in the trial, sometimes it can be difficult to tease this out. And the benefit in those patients may be different if their underlying cardiomyopathy is from an alternative cause or etiology. So which patients could still benefit from PCI? It's important to consider this for our patients which are younger or have limiting angina or symptoms. We know that that can improve, PCI can improve symptoms, if not your overall mortality. And patients with recent acute coronary syndromes would all be indications for this. And in the subgroup analysis of the REVIVED trial, they did see that patients less than 70 with a high BCIS jeopardy score of 10 or above, so significant myocardium at risk, and ejection fractions of less than 29%, all tended to favor PCI in their forest plot and subgroup analysis. Finally, the last point I wanted to make was about the risk of myocardial infarction. Although the acute myocardial infarctions that occurred in both groups was relatively similar, the patients that had optimal medical therapy alone did have a much higher percentage of spontaneous myocardial infarction. And so perhaps in those patients that are at higher risk and then go on to have a myocardial infarction could have worsening scar burden or worsening ejection fraction. Those patients were not specifically analyzed, and so those are the patients that we want to try to protect with revascularization and avoid a further insult. So ultimately, the take-home points are that optimal medical therapy benefits these patients with ischemic cardiomyopathy and severe left ventricular dysfunction. And so first and foremost, we need to optimize their medical therapy with the 4 pillars based on guideline-directed medical therapy and device therapy where appropriate. The addition of revascularization by PCI to optimal medical therapy in the REVIVED trial did not reduce the outcome of death of any cause or hospitalization for heart failure, improve left ventricular ejection fraction, or show sustained improvement in quality of life. And ultimately, long-term follow-up is still required because in many of these other trials, at the later time points, sometimes new findings are developed. So further research is still needed. So thank you all very much for your attention today and to the committee for the opportunity to speak, and I look forward to your questions with the panel.